Hi everyone, thanks for joining. We're going to get started now. Today we have approximately 40 minutes, and just a reminder, one question, one follow-up. We have Dr. Brown and Dr. Yaffe here today, so I'll turn it over to them to get started.
Thank you. Good morning, it's Adalsteinn Brown from the Dalla Lana School of Public Health at the University of Toronto. Before we start today's briefing, I'd like to apologize that when we start presenting the slides, the sign language interpretation will disappear. It will come back as soon as we are done with the slides. I also want to just take a moment to say thank you to the dozens of scientists who work as part of our science advisory, our modeling consensus, and our evidence synthesis tables. They've come from universities, hospital research institutes, agencies, and other groups across the province, and it's been a pleasure to work with them over the last several months. We can go now to the slides. I'll wait for them to come up. Great, thank you. So the key findings are very clear today. The cases continue to grow. Although we've talked about being in a precarious situation, we have seen consistent low-level growth really for about the last 2 months. Overall case levels in the province now are more than twice what we'd call the red level. And the percent positivity, although flattening right now, has increased substantially since 2 months ago. Our ability to control case growth is still very precarious, and this continued low-level growth that we've seen is just adding greater and greater pressures and removing more and more of our ability to control the growth of the pandemic. It's important to note that continuing case growth will increase the number of outbreaks that we see in long-term care homes and other settings where people live together that are quite vulnerable to the spread and the impact of the disease. Under all scenarios, ICU occupancy, even under a zero-growth scenario, will be above 300 beds within 10 days. And the worst-case scenarios show that we'll be above 1,500 beds, essentially about 75% of our entire intensive care unit system by mid-January. We've looked very carefully at the experience in countries like Australia and France, trying to understand the impact of their hard lockdowns that have happened for about 4 to 6 weeks. These sorts of hard lockdowns can reduce case numbers in Ontario, we believe, to less than 1,000 per day if they're of sufficient duration, and if they're matched with increased testing and increased support to people in those communities where exposure to the disease is highest, we may be able to get down to lower than 1,000 per day. With lower case numbers, we will be able to maintain safe intensive care unit care for COVID-19 patients and for other patients who require intensive care unit support. And as noted in previous briefings, the public health restrictions of any sort will require more resources, particularly testing and support for people when they need to isolate or quarantine in those communities where exposure is highest and in essential service workplaces where exposure is higher. This slide updates the slide that we show at the beginning of every briefing. This is a picture of the total new cases per 100,000 residents per week across the public health units here in the province. What you can see now is virtually every line is above the restrict level, and you see continued growth in a number of different jurisdictions, with particularly strong growth in at least 3 or 4 public health units over the last few days. And if you look here, you can see the percent positivity across public health units. I want to talk for a few minutes about the totality of the case numbers, the percent positivity, and testing. Although you see a little bit of recent flattening in the percent positivity, it is at an overall much higher level. It's essentially increased by about 30 to 50% since the beginning of last month. And importantly, we've also seen a substantial increase in testing at the same point, with cases more than doubling over the same period of time. And so you see dramatic growth in cases, a very strong growth in testing, and at least for the beginning of the period, a growth in percent positivity as well, with maybe just a bit of flattening now. That means that we are in a very, very challenging situation in terms of control of the disease. And this slide shows you the percent of COVID-19 test results returned within 2 days across the public health units. You can see here this continuing picture of regional variation that we see with virtually all of the indicators that we look at. The regional variation here, though, is about twofold, which is a really important variation to look at. Getting test results back to people quickly is critical to control of the disease. It's critical to helping people isolate. It's critical to case and contact tracing. And so very prompt return of COVID test results as quickly as possible is an important indicator. And you can see both below goal here in a number of areas, but also substantial variation across the province in access. And you can see here the percent positivity by age group. Really starting back in April at the left-hand side of the chart, you can see very, very dark squares. Each square represents a week since the beginning of the pandemic and a age group such as 75 plus at the top of the chart. You see it lightens during the summer, but you can see now this continuing trend towards darker and darker squares, despite a much, much higher level of COVID-19 testing in the province. Important to note as well that we see growth in the percent positivity in our two most vulnerable groups, people really above 65 and above 75. Overall percent positivity is down in less vulnerable groups, but growth in percent positivity in the most vulnerable groups. This is the start of the projections here for case growth in Ontario. You can see we continue to track other jurisdictions. And this is despite a number of the restrictions that have already been put in place. In some ways, this is not surprising given what we've seen in other jurisdictions as well with accelerating growth. And a few slides on, I'll show you a picture of how that looks in those other jurisdictions. However, if we continue on at about 1 to 2 to 3% growth, we're going to be between about 3,000 and 5,000 cases by the fourth week in January. If we see substantial growth at 7%, similar to what we might see as similar to other jurisdictions where it's taken off, you could see greater than 30,000 cases by the end of January. So important to note that we're in a place still with very, very strong growth potential, and even flattening of the curve, just about 1%, which we've seen as a very consistent sort of 7-day average growth rate. You'll still see almost 3,000 cases a day in the province. And continuing on, you can see the impact of this growth in cases in terms of the growth in hospitalizations and ICU admissions. The last time we presented the 4-week growth, it was about 92%. Today it's about 69%. We have about 83% increase in ICU admissions, and that's about, in ICU patients. That's down, thankfully, from about almost 166% the last time we presented this. However, this pattern of growth at a substantial level continues as it has pretty much since we began these briefings in the earlier fall. And you can see here the impact of this growth in cases and growth in hospital admissions on ICU occupancy. Under any scenario, we are now above 300 beds by the end of December, even under a zero growth scenario from here on. And in more severe scenarios, for instance, a 7% growth in cases, we will have about 1,500 ICU beds occupied with COVID-19 patients by the end of the third week, beginning of the fourth week of January. So significant growth, even at 3%, which is less than we've seen over the last several days. On average, you still see about 600 beds occupied by the end of January. It's important to note, too, that this is not an issue of a small amount of ICU occupancy being consumed across every intensive care unit in the province. It is clustered heavily in those regions that we showed at the beginning, with quite significant impacts on access to care and impacts on the quality of care. On this slide, we're just taking a minute to make a couple points about the importance of maintaining ICU occupancy at a manageable level. The first thing I want to note, and if you look at the bottom left-hand panel, that top bar in that chart that's labeled elective, about 15% of total ICU admissions, that's the bit of ICU care that essentially can be played with or delayed, perhaps rescheduled, related to surgery. If you look down below at the non-elective, the 85% of the total, that's really the portion of ICU care that cannot be delayed. And so this is any number of different reasons for admission, whether it be heart attacks that need immediate and intensive care, accidents, trauma, any number of other issues. It's not as if we have the total number of beds to deal with. It's a very small portion that we have while trying to maintain access to necessary care. And then if you look at the right-hand panel, you get a sense of how the occupancy level varies with the impact on access to care. As occupancy levels rise, regardless of how many number of beds you have in an intensive care unit, you see an increasing risk of delayed access to care. And we know from previous studies that decrease in access to care actually leads to an increase in mortality. So you really start to see here COVID-19 impact on the ICU playing out in terms of increased mortality in a number of ways. It delays access to necessary care. We'll show a chart on the delays in access to surgery and other types of care shortly. It impacts, obviously, directly through people who have COVID-19 and die in the intensive care units. And it delays access for people who need intensive care, adding further to the mortality. And you can see here the continued impact on access to care. The red line on this chart reflects access to care at 2019 levels. If you look, for instance, at the purple line, that is access to surgery. The beginning of the year, over on the left-hand side of the chart, you can see it's roughly paralleling the 2019 levels. In the first wave, it drops precipitously. You can look at that space below the line as really reflecting all the people who did not get access to care. It comes back up after the surgical restart for a period of time in August and actually crosses the 2019 levels, but then since then has really been below 2019 levels. And this is delayed access to care for heart disease, for cancer, important orthopedic procedures. It's not elective or easily delayable care in many cases, and this in itself will have a significant impact on health. You can see a decline as well if you look at the beige line on diagnostic imaging, MRIs, CTs, and other tests. And you can even see a decline in access to emergency room care, which includes not only sort of low acuity, but also high acuity emergency care, suggesting a continuing deficit that will have impact on care and on outcomes for a while. It's also important to understand that the spread throughout the community has a significant impact on our long-term care homes. And so the biggest predictor of an outbreak in a long-term care home is the spread of the disease in the communities around the long-term care homes. It gets then into the long-term care home or other congregate settings and leads to a significant impact in terms of further cases, hospitalizations, and deaths. It's important to note as well that these communities from where people who work in long-term care homes come are the same communities that face the long-standing structural barriers around access to suitable housing, the need to work in essential frontline work such as personal support workers, and multi-generational housing that lead to higher spread, that lead to higher exposure and higher spread of the disease. And so if we see, as we talked about before, that the disease is inequitably spread across the province, that it hits communities facing barriers around access to suitable housing, where they've got strong amounts or high amounts of multi-generational housing, and where there's high percentages of people needing to work in this type of essential work, you'll actually see an increased spread into long-term care homes with obviously disastrous consequences in terms of mortality and hospitalizations. Once the disease is in the long-term care home, the spread throughout the long-term care home and the impact in terms of mortality is really a function of crowding, multi-occupant rooms, or a work where people work in one long-term care home, an older ownership, older design of the homes. You can see that there's been a substantial reduction if you look at some of the data on our website in the number of residents in 3 to 4 bedrooms in crowding, but there are still about 3,500 residents in 3 to 4 bedrooms. This growth in cases in long-term care homes translates to growth in mortality. You can see this consistently increasing amount of mortality at a fairly consistent rate right now, about 100 deaths in the past 7 days. At our last report, it was 102 deaths in the 7 days preceding. But yesterday's count from the long-term care tracker was about 21. So potential for significantly increasing death rates here and death numbers here as well, and also consequences in terms of higher rates of hospitalization and strain on our healthcare system. Overall, mortality is continuing to increase as well. When we last talked about mortality, we felt it would be perhaps between about 25 and 30 a day at this time. I believe it was 26 today, but it's tracking higher. Yesterday it's tracking higher and higher as we look at this, with the potential that if case rates continue, we will look at a most likely estimate of about 50 deaths a day by the middle of February. There's a very good paper that's just come out by Mol Verma and Fahad Razak and colleagues that looks at the death rate and hospitalization in the first wave compared to flu. The death rate is about 5 times as high, with significantly greater risk of ICU care and ventilation when in the intensive care unit. So this is not to be confused with just a wave of flu. This is a different disease with very different health consequences. Now, Ontario continues to follow along the path of other jurisdictions. You can see here the curves for countries such as the Netherlands, France, the United Kingdom, and Germany. They moved into their second wave earlier than Ontario and Canada. You can see Canada is the dark blue line at the bottom. We're starting to track there up, and that dark blue dashed line that goes straight across tells you where we are in Ontario right now at about 133 cases per million people a day. What's important to note is that virtually all of these jurisdictions have seen growth until they have implemented some form of a harder or more stringent lockdown. There's been no self-correction in the disease in any of the jurisdictions that we consider pure jurisdictions right now. And so without action, which all of these countries have done to bring it down, you will likely see continued case growth and a great risk of that accelerated case growth as you see in that big spike in France or that big spike in purple as you see in the Netherlands. On this chart, we're showing the case numbers and what happens to them following a lockdown in both Australia that started at a much lower rate of cases. They started their lockdown below 100 cases per million population, and what happened in France when they started at about 700 or 800 cases per million population. Just to remind people, we're about 133 right now, so we're between where Australia was when it started, but not yet where France was when it started. In both cases, hard lockdowns with very, very clear communication around the need for the lockdown with very stringent sort of enforcement or other issues to make sure the lockdown works, but also, we'd argue, with a great need for support of people during this period of time. You can see a very significant shift downwards, despite the different levels at which they've started, a very similar as well as significant shift downwards in the number of cases. In Australia, about 12 to 16 weeks, depending on how you look at the duration of the lockdown, and in France, about 7 weeks. And if we look at this in Ontario, I want to just talk about this chart for a while. You can see the impact on case numbers of different durations of a hard lockdown. Based on what we saw in Australia and in France, cases will continue to grow. If, for instance, we started a lockdown on the 28th of December, that's what this chart shows. Cases will continue to grow for a period of time. Then the decline in contacts between people will start to take over and case numbers will come down. However, it's really critical to note that the duration of the lockdown has a very big effect. At about a 4-week hard lockdown, you see case numbers under 2,000 per day under the 3 scenarios we've modeled here. But after 6 weeks, under 1,000 cases per day under any of the scenarios we've modeled. If you look, for instance, at the top, the darker orange line, if we see strong growth between now and the 28th in the number of cases, for instance, if there's a lot of social interaction around the holiday time, people are visiting, if there's events where there's crowding into small enclosed spaces, and we see a substantial growth in the cases between now and then, you actually will still get to a place where the total case numbers exceed 5,000 before you start to come down, and it will take longer. It'll take about 50% longer to get the numbers under 1,000 cases per day. If instead we see really kind of a steady state around 2,000 cases until a, say, 28th of December lockdown would start, you can see a much quicker decline under 1,000 cases, with that happening well under 1,000 cases by the end of 4 weeks, and likely under 500 cases a day by the end of the 6 weeks. So a substantial dividend in terms of reduced cases. However, we believe this would be even more effective and you'd see an even larger drop in cases if there is more support for communities, where we need support for isolation, where we need a stronger community engagement. And it would be obviously better with stronger adherence to the measures within the lockdown, and obviously better with greater access to testing that people can get to and that works for them. The stringency of the lockdown is very important. Last briefing, we talked about the changes in mobility following the current set of restrictions that have been imposed. What you can see here is a relationship between the stringency of the restrictions and the degree of mobility. This shows you the mobility index for a number of different provinces across Canada. That green line that dips well below the other ones is Manitoba, that really started the most strict of the lockdowns that we've seen across the country on November 12th. And you can see it starting to come down here with a big dip in mobility compared to other jurisdictions. This change in mobility will take a time to filter through to a reduction in the number of cases, but stringency is important. And it's important to note, too, that the timing of when this lockdown, if there is a lockdown, starts is really important. If we started on December 21st instead of December 28th, it plays out significant reductions in cases under almost any scenario. And so even if we saw 0% growth in the overall number of cases between now and December 28th, starting earlier, starting today, would still reduce the total number of cases by 800 by December 31st. But by the end of the month, by the end of next month, it would reduce it by over 11,000 cases. And if you look under the more negative scenarios in terms of growth, if we started on the 21st instead of starting on the 28th, and we had about 5% growth going into the lockdown, you would see over 45,000 fewer cases in the province, with a significant impact in terms of reduced mortality and a significant impact in this case, if we went earlier, in terms of lower ICU use. So just to return to the key findings, cases continue to grow and overall case levels are high now. Although the percent positivity is flattening, it's important to understand that percent positivity has increased substantially since earlier in the fall. And the ability to control case growth is very precarious and continues such. We will see continuing case growth, which will increase outbreaks in long-term care homes and other congregate settings, which will translate to increased mortality and increased hospital use. Under all scenarios, ICU occupancy will be above 300 beds. This is the second of the thresholds that we discussed earlier in the year. This means that we will see cancellations of surgery, we will see reductions in access to necessary care, and we will see the risk of delayed access to care, intensive care unit care for people who truly need it, immediately under any of these scenarios. And this impact is heavily clustered in a relatively small number of hospitals in our most hard-hit communities. If case growth continues, under the worst-case scenarios, we'll be above 1,500 beds by mid-January. And it's important to note here as well that this is not simply an issue of more beds in intensive care units. There's highly trained staff that are needed to care here. And even with new staffing models where we use people who don't work in intensive care units to provide this care, you will see a corresponding reduction in access to other procedures. So regardless, there will be a significant impact on access to care. Based on experience in France and Australia, hard lockdowns, very stringent lockdowns, a very strong communication of 4 to 6 weeks can reduce case numbers in Ontario. The duration of the lockdown is very important. The starting level of cases for the lockdown is very important. And we believe, as well as we've said in the previous briefings, that strong community support and increased testing volumes will have a dividend to pay here and actually help reduce case numbers down even further. With lower case numbers, we will be able to maintain safe ICU care for COVID-19 and COVID-19 patients who require this. And just to emphasize again, these are not elective patients. These are patients who need immediate intensive care. And so not something that can be delayed, and we need to think both of reducing the burden of COVID-19, but also the way that COVID-19 patients create a barrier for other patients who need care. And as noted previously, public health restrictions do require more resources, more testing, and more support for isolation, more support to allow people to isolate when they test positive in communities and essential services, workplaces where exposure is higher. And with that, we're done the briefing, and I believe we can go to questions now.
We'll go to the phone lines. Just a reminder, one question, one follow-up. Over to the first question, please.
First question comes from Ashley Legasic with News Talk 1010. Please go ahead.
Hi, thank you, doctors, for taking my question. I'd like to hear from both of you about what specific actions need to be taken right now to achieve the results that you spoke about today? And when would you recommend that these measures be implemented?
Okay, I guess I'll start. Good morning. Thank you for the question. We're in a very, very challenging and precarious situation, as Dr. Brown has outlined. And we do need to have measures that will reduce people interacting with other people that don't live in their household. And those specifics of what's going to be in place in Ontario will be announced later on at 1 o'clock. I know there have been many emergency meetings and discussions over the weekend with the Premier, Cabinet, and experts to figure out what the best thing to do is, and to do it, I would say, obviously, as soon as possible, but also giving time for people to prepare for the changes that are coming. I'll turn it to Dr. Brown.
Thanks. So the modeling that we present and the analysis that we present in the deck is the result of teams working across a number of different universities, teams at University of Toronto, University Health Network, teams at Unity Health here in Toronto, teams at McMaster University, teams at Public Health Ontario here within the Ministry of Health and Ontario Health. And it is a very consistent picture across all of these analyses. The earlier work starts to reduce the contacts between people and support people who need to isolate at home, the lower the case numbers will be. So earlier, always earlier is better on this. I don't think there's any disagreement among all the scientists on this. And second, activities that reduce the number of contacts are really important. So anything that keeps people at home, allows them to be at home, supports them to be at home is critical. Reducing that mobility substantially, as we've talked about over the last two briefings. And also things that reduce the likelihood of transmission when people come into contact with others. So although there persists some debate, I believe popularly about the question of masks, there's, I don't believe, any real debate among the scientific community that masking and masking more and in more settings can be helpful. But finally, I think it's important to note that case rates still remain highest in those communities that face long-standing structural barriers. Problems like lack of access to suitable housing, precarious work, multi-generational households, needing to go to work to be able to put a food on the table. In these sorts of communities, unless there's strong support for people to isolate and stay at home, we will not be able to get control of the pandemic.
Follow-up?
Thank you very much, both of you. And Dr. Brown, you did just touch on it a little bit, but I want to dive a bit deeper. Where exactly are people getting infected right now? As of today, where is the biggest problem? Is it shopping, schools, workplaces, indoor gatherings?
Maybe I'll turn to Dr. Yaffe to talk about the outbreak data or where the transmission is, and I can talk about what's in the literature afterwards.
Sure, thank you. The bottom line is there are outbreaks anywhere that people congregate, anywhere that people are interacting with other people. So, we have outbreaks, obviously, in long-term care facilities, retirement homes, jails, correctional facilities, shelters. We have outbreaks associated with malls, day nurseries, schools, and in many cases, as Dr. Brown said, they are reflecting the rate of infection in the community. So if you're in a community that has a lot of COVID, it will spread into these settings. And in some of these settings, like long-term care facilities, it can spread very quickly. And it's a very vulnerable population, so you'll see a lot of cases, a lot of hospitalizations, a lot of deaths. And so the bottom line is we have to focus on the whole community, not just specific settings.
Next question.
Your next question comes from Lorenda Redikoff with CBC News. Please go ahead.
Hi there. I'm looking at the graph on page 7, and so we see, those various arcs up, and we see those every time with these modeling projections, and sometimes those possible case numbers, they just seem out of control, and then we never get close to that. So how would you describe to people, where are we at now in terms of that graph, and what do these numbers really mean?
So we've gone through a period now where we've seen a series of restrictions, and I think sometimes people look at the restrictions as being an on or an off switch. they don't have that sort of an impact. Putting restrictions in, I believe, has actually started to slow what was the potential growth here. If you go a little further on in the presentation, you look at what happened in a number of those other jurisdictions, there was that explosive growth. We began to put in Ontario a number of these softer restrictions, as you've seen, across a number of the different public health units in place earlier. We're still about a month and a half to 3 months ahead of a number of the other jurisdictions. And so you're actually seeing not the most explosive growth yet, but you're still seeing this continuing sort of low-level growth. What that means is that we continue to kind of play in the area of, say, the 1% growth scenario, the 2% growth scenario, that sort of low-level growth. And that's really, I think, a function of the restrictions that are in place now. But they can continue, and if you get a series of super spreader events, as we see in other jurisdictions, or you see a decline in compliance with the public health interventions, you will see higher and higher levels of growth, as you did see in a number of other jurisdictions as well. And so that, the biggest challenge in communicating the modeling is that each time we present the modeling, there are changes. There's changes in policy, there's changes in behavior, and these affect where the curves are. But where we are is still sort of boiling along at that, or simmering along at that 1% sort of level of growth.
Follow-up?
And in terms of the idea of a hard lockdown, how long do you think one needs to be implemented? And then you talk about extra supports. What is needed in terms of those extra supports to protect these more vulnerable communities?
So in terms of the length of the lockdown, in the slides that were shown, we don't believe anything less than 4 weeks will be effective, and longer durations will be more effective. 6 weeks gives a significant added likely reduction in case numbers. They won't start coming down right at the beginning of the lockdown necessarily in a way that would, I think, give people reassurance, but they will come down over time. In terms of extra supports, it's everything from making sure that people don't have to choose between going to work or putting food on the table, so income support is critical. It's issues about safe isolation and quarantine, so the ability to either move to an isolation hotel or move family members out if you need to isolate at home and you don't have space. It's eviction moratoriums. It's very, very clear communication, working with communities to make sure that people understand the importance of testing and adherence to the public health interventions. And it's providing testing that really makes it easy for people to get to the testing, so that it is next door to apartments where there's high rates of infection, that it's in community centers or in places where it's easy for people to get to and they don't require a car or driving or traveling on public transport.
Next question.
Your next question comes from Laura Stone with the Globe and Mail. Please go ahead.
Hi, Dr. Brown. I just wanted to follow up on Lorenda's question about lockdowns. What is the difference between the lockdowns that we're seeing now in the lockdown zone and a so-called hard lockdown? I mean, you compare it in the modeling to France and Australia. Are we talking about curfews? Are we talking about stay-at-home orders? Can you just explain to the public that's looking at that term, hard lockdown, and tell us what that means?
Sure. So there's variation, for instance, or there's differences, for instance, between Australia and France, but there are some consistencies as well. So in both jurisdictions, they saw really kind of very strong stay-at-home directions. Each jurisdiction or each country implemented it differently, but really stopping people going to work if they can work at home. It was very strong control about traffic and gathering. For instance, both jurisdictions used curfews. There were some variations in the types of businesses that were allowed to stay open, but in both jurisdictions, again, non-essential businesses closed, and there were reductions or restrictions in operating for other businesses. And finally, I think what was really very important in each jurisdiction, although they pursued this differently, was to communicate the seriousness of this so that people did stay at home. And there's different ways to do that. But if you just look out on any of the streets in downtown Toronto, the amount of street traffic is much higher than you would have seen during the spring. If you just, I look out of my apartment every morning and it's like it was in January or February, not like it was in April. So there's a lot of movement, a lot of contacts, a lot of exchange, and both jurisdictions were very clear about communicating that. And as you've seen, other jurisdictions such as Germany need to kind of communicate even more strongly and put more measures in place to try to control that.
Follow-up?
And I wanted to ask you just on a different matter regarding the statistic from December 10th about the epidemiological links of cases and Toronto Public Health having 70% no epilink. The health unit's disputing that, saying it's now 12%, and Public Health Ontario says it should have been classified as no information versus no epilink. I wonder if you can just comment on this figure. What's the difference between no information and no epilink? And is the issue really that we still don't know where cases are coming from in Toronto?
Right. So we're working right now with Toronto Public Health, and we actually receive our data from Public Health Ontario. So we're working to understand what is happening in that data. And the next time that we present it, we'll actually have a good picture. I wouldn't feel comfortable right now presenting it because we haven't had time to really go in and understand the differences in the data.
Next question.
Your next question comes from Shalima Maharaj with Global News. Please go ahead.
Hi there. Thank you for taking my question. I was looking at the positivity by age group weekly assessment, and you mentioned some of those vulnerable groups, but one group that seems to stand out as well is that between 14 and 17 years of age, their number seems to be quite significant, going from 1 week in December to 6.8, now most recent to 6.2. Where are we seeing this transmission coming from? What kinds of settings? I know you mentioned any kind of setting that people gather in.
Harvey, want to talk to this? It's outbreak data.
Yeah, basically these are teenagers, and anybody who's had a teenager knows how hard it is to control their behavior. But anyway, these are basically kids that have either gotten it from other kids or from their parents often, or in the out in the shopping malls or whatever, different settings like that.
Follow-up?
Yeah, absolutely. We've also been seeing a lot of long lineups outside of shopping centers and big box stores. What are we seeing as far as the actual rate of transmission in those types of settings? And are further restrictions warranted in terms of, capacity, for instance, in those types of settings?
So are you talking about lineups at malls? Is that what?
Lineups at malls and as well at big box stores. I know there are obviously capacity limitations right now for those who are in the gray lockdown zones, but just across the board, are you seeing numbers that suggest to you that more restrictions are warranted there?
I'm not sure that the data actually is that specific, but I would say that certainly, we've seen big lineups, lots of people perhaps not keeping the 2-meter distance between each other, not wearing their masks properly. This is one of the issues that I think is worth mentioning is a lot of people don't wear their mask properly. They think, well, I'm wearing my mask, I'm good. It has to fit closely over your nose, mouth, and chin. And many people seem to put it under their nose. So we have people not keeping the right distance, not wearing their mask properly, and talking with each other and potentially spreading the infection. Big box stores, yes, it's an issue, I think, and we need to look at how do we reduce the number of people that are going into big box stores as well.
Last question.
Your final question comes from Pamela Van Meer with Kawartha 411 News. Please go ahead.
Hi there. Thanks for taking my question. As of today, there were approximately 915 people in hospital in Ontario with COVID. Back in April, the Financial Accountability Office released a report saying there was 22,358 acute care beds in Ontario before the pandemic. 21,425 were taken, leaving 910 beds for COVID patients before the pandemic. Since then, the government has announced 3,303 new beds for COVID patients. On April 16th, they announced more than 1,000 acute care beds and 1,492 new critical care beds. Then on October 27th, they announced a further 776 new beds. So what happened to all of those new beds?
Well, I can start. I think that beds are obviously very important, but a bed is of no use without the human resources, the staffing that are often very technical and need to be trained to staff those beds. So they are being implemented, as well as looking at the staffing. I think we need to look also at, as time passes, our population is aging, and we have more people who need procedures or have serious health issues. And we have more people in general. So there are a lot of different factors playing into this, but I think the big thing to remember is a bed alone is useless. You need the staff to go with it.
Follow up, and this is the last question.
The government has had 9 months to address those staffing issues. What have you done?
There's a lot of work happening around that, and but you can't just produce a trained nurse out of the thin air. And there are a lot of different programs happening to increase staffing for nurses, PSWs, and others.
Thanks, everyone.